figure, middle figure. Then the retroauricular hairline incision, that is for the cosmetic purpose, mostly used in the robotic surgeries, and then the facelift incision. Then the flaps. So flaps are again a very important part in the parotidectomy. After raising the flap, we first look for the greater auricular nerve and the external jugular vein and try to preserve both of these structures after identification. And for the raising of the flap in the face, the anterior skin flap should be raised superficial to the parotid fascia, leaving the subcutaneous fat on the flap. But if the tumor breaches the capsule, then we have to leave the fat on the capsule for the margin. Plane, and in the posterior part of the neck, it should be deepened to the sternocleidomastoid, and then the greater auricular nerve can be seen easily. Then, after raising the flap, the structures which I already told, that the external jugular vein and the greater auricular nerve are seen, and they should be preserved. So greater auricular nerve travels parallel to the external jugular vein, and it splits into the anterior and the posterior division at the level of tail of parotid. So any injury to this nerve can cause loss of sensation in the skin at the angle of the mandible, the side of the upper neck, and the inferior half of the external ear, which is specifically more important in females for the piercing. But for the anterior branch, it is quite impossible to preserve the anterior branch of greater auricular, as it overlies the tail of parotid, and it hampers the exposure of the gland while raising of the flap. So posterior branch is preserved. Also, the posterior branch is also preserved because in case of the facial nerve injury or the sacrifice of the facial nerve, the greater auricular nerve can be used as a nerve graft for the reanastomosis and facial reanimation. Then the most important structure in the parotidectomies is the facial nerve. So any relevant anatomy is limited to the extratemporal portion. That is, after leaving the stylomastoid foramen, the facial nerve, the main trunk of the nerve, divides at the pes serenus, which further divides into the superior division, that is the temporofacial, and the inferior division, that is the cervicofacial branch. Superior division again divides into frontal, zygomatic, and buccal, and cervicofacial divides into marginal and cervical branches. So this was the basic anatomy of the facial nerve. But for the surgical part, we need to find the basic landmarks to identify the facial nerve during the surgery. The most accepted landmark is the posterior belly of digastric. The facial nerve trunk lies approximately 1 centimeter above it, above the digastric, posterior belly of digastric, and parallel to the upper border of digastric. So this is the digastric muscle in the picture. And second is the tragal pointer. So the facial nerve is around 1 centimeter deep and inferior to this pointer. It's a cartilaginous pointer seen in the dissection. Then is the stylomastoid foramen. It is actually a palpatory landmark, uh, and any excessive dissection in this area can cause permanent paralysis of nerve because of the thick fascia on it, but it is a landmark for identification of the nerve. Then is the tympanomastoid suture. It is palpable as a hard ridge deep to the cartilaginous portion of external auditory canal, but the facial nerve is just a few millimeters deep to its outer edge, the tympanomastoid suture. Then is the mastoid process. It is again a palpatory landmark, and the process lies deep to the sternocleidomastoid. Then after the regular landmarks that are used for anterograde dissection, some are the retrograde. We'll be discussing the retrograde identification of the nerve, which is used for the resurgical cases or for bulky tumors. So for the retrograde identification of the facial nerve, peripheral branches of facial nerve are identified first. then the main trunk is reached. So various nerves can be located, like the buccal nerve, which is 1 centimeter below the zygomatic arch. And also in the literature, it says that the buccal nerve can be identified with the help of Stenson's duct, that is the parotid duct, as the superior branch of buccal nerve is approximately 1.8 centimeters superior to the Stenson's duct, and the inferior branch of buccal nerve is approximately 2.5 centimeter below it, and it goes parallel to that. Then is the marginal mandibular nerve and the frontal branch of facial nerve, which can be identified as a retrograde dissection. The marginal mandibular nerve can be identified at the angle of the mandible as crossing the facial vessels near the angle of the mandible. And for the frontal branch, it's like an imaginary line drawn 0.5 centimeter below the tragus to the superior edge, approximately 1.5 centimeter from the lateral extremity of the eyebrow. Then after identification of the nerve, we trace the pes and all the divisions of the branches, all the division of the facial nerve. Then we can retract the tumor over the facial plane. We can use either top to down or down to top approach in this. So the current concept says that we can use partial or adequate parotidectomy for the dissection. That means if the tumor is superior, then we can leave the lower branches undissected, and if the tumor is inferior, then we can leave the upper branches undissected, so that the chance of injury to the branches of facial nerve decreases. If there is a deep lobe involvement, then the facial nerve is carefully separated and retracted. Then the deep lobe is taken out. And for the radical parotidectomies, we manage the facial nerve and the cervical nodes according to their involvement and extent, which we'll be discussing later. So this was the basic surgical concept behind the parotidectomy. Parotidectomies are classified by European Salivary Gland Society into parotidectomy and the extracapsular dissection. So the European Salivary Gland Society divided it into parotidectomy and extracapsular dissection. For parotidectomy, they gave a prefix for the side of the parotidectomy to be done, either right, left, or both. So they are separately mentioned even if both are involved. Then the levels that has to be removed for the parotidectomy. So European Salivary Gland Society gave the classification for the levels, that is lateral superior, lateral inferior, deep inferior, deep superior, and the accessory lobes of parotid. According to these, the Roman numerals are used against each levels to define the extent of the parotidectomy. And third component of the classification was if we are taking out any non-glandular structures like masseter bone, external carotid artery, facial nerve, masseter muscle, then we have to specify them according to this nomenclature. Then second component of the classification is the extracapsular dissection, which is represented as a ECD, and similar to the parotidectomy, the prefix would be right, left, or both. And the second component is the level involved. For the extracapsular dissection, it is a newer described technique of removing the tumor and its capsule along with a thin rim of normal glandular tissue without the formal dissection, identification or dissection of the facial nerve. So literature says that it leads to less chances of facial nerve injury, but has similar recurrence rates as seen in the superficial parotidectomies. It gives a better scar, but the need for expert hands, because it's a very meticulous dissection to take out the tumor with a small rim of normal tissue around it without causing any spillage that can further lead to recurrence. Expert hands are required for the surgery, and if possible, then intraoperative nerve monitoring should be used. Then the various types of parotidectomies, which I named earlier. I would be discussing about the types and the extent of these parotidectomies. So extracapsular dissection, I'm summarizing as small tumors with a small tissue removed. This type of parotidectomy. It is indicated in purely benign lesions. Facial nerve is not identified in this case and in this type, and if possible, intraoperative nerve monitoring should be used to reduce the risk of facial nerve injury. Then is the superficial parotidectomy, that is limited to the superficial lobe only, and the tumor is resected from the superficial lobe with the cuff of parotid tissue. For the partial and adequate parotidectomy, it involves a complete removal of the tumor without the capsule rupture, with approximately 0.5 to 1 centimeter of tumor-free margin from the superficial lobe. Indications for these parotidectomies are benign lesion and lymph node metastasis into the superficial lobe. In this case, we identify and preserve the facial nerve. For total parotidectomy, the entire gland, both the lobes, the superficial and the deep lobe, are removed. These are indicated for aggressive malignant tumors, deep lobe tumors, sentinel lymph node excision when located in deep lobe, and where there is no distinction between the superficial and deep lobe because of the involvement of the aggressive malignant tumor. And in this case, we identify and preserve the facial nerve. Then is the radical parotidectomy. In this parotidectomy also, we take out both the lobes, and the facial nerve is also sacrificed. It is indicated in high-grade malignant tumors, and facial nerve is not preserved, but we can reanastomose if we are preserving any branch, or we can do facial reanimation as a second stage procedure for these. Then coming to the decision making for the extent of parotidectomy, when to do a parotidectomy, which is the most important part in the surgical management of surgical treatment of the parotid tumors. So decision making in the parotidectomy is taken at various points, like the type of tumor, the histological grade of tumor, the nerve, facial nerve status, and the status of neck node. So for the histological grade and the type of tumor, WHO classification, which was described in the previous session, that is, the tumors are divided into benign and the malignant can further be divided into low grade and high grade, low aggression and high aggression tumors. Based on that, the parotidectomies are defined. So parotidectomy in benign and low grade tumors, earlier intracapsular dissection, that is the enucleation, was done, but because of unacceptably high local recurrence rate, it is not done now. So partial superficial parotidectomy or adequate parotidectomy is done, and superficial parotidectomy and extracapsular dissection is also indicated. So the techniques I've discussed earlier. For the superficial and extracapsular dissection, there is a controversy regarding the two procedures. So basically, it was earlier said that the recurrence rate and the chance of facial nerve injury was low in extracapsular dissection. But after a study by Kedles in 2017, it says that there are high chances of facial nerve injury in extracapsular dissection, because we go in the extracapsular dissection as a blind procedure. So he gave a percentage of 7.2% facial nerve injury in extracapsular dissection as compared to 2.2% in the superficial parotidectomy. And similarly, he gave for the same rates for the recurrence also in the extracapsular dissection as compared to the superficial parotidectomy. Then parotidectomy in high-grade parotid tumors. So deep lobe spread can occur both in the superficial parotid cancer, as well as they can occur from metastasis of from skin and other cutaneous carcinomas. As described by Thom et al., in 22% of the superficial parotid metastasis from the cutaneous squamous cell carcinomas and melanomas that were found to have deep lobe metastasis. For the treatment, again, the superficial parotidectomy overlaps the treatment in both the low grade and the high grade. For the treatment of high grade, the superficial and the total parotidectomy can be done. Again, there's a controversy that when to do a superficial parotidectomy and when to do a total parotidectomy. So high grade parotid cancers with parotid regional metastasis, at least a subtotal parotidectomy should be done in order to optimize the nodal clearance while trying to maintain the facial nerve function. So subtotal parotidectomy is indicated. And for those in which the deep lobe cancers or the deep lobe metastatic node is present, a total parotidectomy is recommended, as the parotid nodal metastasis rate is very high, almost 8 to 80%, and has high risk of local recurrence. For the intraparotid nodal metastasis in high grade or advanced, superficial parotidectomy with consideration of total or subtotal parotidectomy should be done. Then when to decide for the resection of facial nerve and when to preserve it. So for the management of facial nerve, we require a preoperative evaluation. When the preoperative normal facial nerve function is seen, we need to preserve the facial nerve. And intraoperatively, when we see the plane of separation is present clearly, then we should preserve the facial nerve. In situations where there appears a tumor infiltration or the encasement of nerve completely by the tumor, as in case of high grade malignancies, then we need to sacrifice the facial nerve, but we need to first confirm histologically before the sacrifice of facial nerve. Then when a nerve needs to be resected, it is important to try to obtain frozen section for histologic confirmation of the tumor clearance on the proximal and the distal end margins to completely remove the facial nerve involvement. Then if there is distal branch involvement, it may be possible to save more proximal branches. But when all the branches are involved due to the proximity of pes and serinus to the stylomastoid foramen, counseling for the potential need for mastoidectomy should be done preoperatively. And the effects of facial nerve injury and the sacrifice should be explained to the patient in detail. And in case of sacrifice, if possible, facial nerve reanimation should be planned as a second stage surgery. Then for the cervical node metastasis and management, for the low grade malignancies like basal cell carcinoma, adenocarcinoma, the risk of occult metastasis is quite low, around 5%, and neck dissection is not recommended in these cases. But for high-grade malignancies like mucoepidermoid and undifferentiated carcinomas, the rate of recurrence is high, around 15 to 20%. For these, the elective neck dissection is recommended, especially in T3, T4, and high-grade malignancies. So decision for neck dissection in clinically N0 neck, the primary predictors are the T3, T4 tumors, the high-grade histologic grade tumors, extracapsular invasion by primary tumor, and the lymphovascular invasion and invasion of major nerves, which can be seen after the first surgery, and then a staged neck dissection can be planned after that. For the extent of neck dissection to be done, in an article by Ali et al., he found that clinically N0 patients were found to be N positive following elective neck dissection, and the involvement was seen in level 2 or 3 mostly. And so for clinically N0, at least level 2 to 4 should be done as a neck dissection. And for clinically positive neck, the level should be 1 to 5, as described by Lim et al., which showed that lower rates of level 5 disease were seen in clinically N0 patient, but high rates as high as 82% were seen in clinically positive necks. Then the complications and the long-term sequelae related to the parotidectomy are the wound hematoma infection. Then the facial nerve paralysis could be transient or permanent. Then the gustatory sweating, that is the phrase syndrome. That can happen because of aberrant regeneration of sectioned parasympathetic secretomotor fibers of the auricular temporal nerve with the inappropriate innervation of cutaneous facial sweat glands that can cause the sweating in the area. It can be checked with the iodine starch test. I won't be going into the detail of this. Then next is the salocele and the first bite syndrome. First bite syndrome also occurs by the loss of sympathetic innervation of parotid gland, mostly in the deep lobes because of the deep lobe resection. Then long-term sequelae include the cosmetic, that is the loss of facial contour, the scar, and hyperesthesia because of the injury of greater auricular nerve.
Dr. Rudra, please conclude.
Yes, sir.
Please conclude.
Yes, sir. This is the last slide. So the take-home message is typically the proper workup should be with imaging and clinical examination using fine needle aspiration. And for the primary tumors, the adequate margin is required. And for the high-grade tumors, we plan it according to the extent of the disease and then plan accordingly for the facial nerve involvement and the cervical metastasis. That's it, sir.
Thank you, Dr. Rudra.
Yes,
So
ma'am.
I'll ask you a question. If you have to do a retrograde nerve tracing, which nerve you will prefer?
Uh, Ma'am, according to literature, buccal nerve, as it is more thick and more prominent, it should be identified. But since we are mostly dealing with the marginal mandibular nerves in the neck dissection, we can trace it easily and then follow it till the pes and then identify the other branches of the facial nerve.
What will be your choice for tracing
Ma'am,
if you have to do?
Ma'am, I think marginal mandibular personally because we are well versed with the neck anatomy. So it is easier to find the marginal mandibulectomy at the angle level and then tracing it retrogradely to the pes and identify other nerves.
Okay. And if you have to anastomose any particular peripheral branch, which branch would you preferably anastomose if you have sacrificed all the branches?
Ma'am, the preference for anastomosis should be the frontal branch, which supplies the eye and the eyelid, so that the function of eye improve. And after that, we can do the marginal mandibular nerve for the reanastomosis.
Dr. Rudra, Dr.
Yeah.
Rudra, what is the
Hello.
why you don't do the retrograde dissection in all the cases? You can do in all the cases. What is the disadvantage?
So blind dissection to find the branches can cause injury to the various branches because the other landmarks are the solid landmarks and
Yeah, they are very good landmarks for marginal mandibular. Can identify you identify every time in your neck dissection.
so by identifying other landmarks we can easily identify the branches of facial nerve without injuring them. And by blind dissection, basically retrograde dissection is mostly indicated in re-surgery cases or when the nerves are displaced because of bulky tumors. So the proper location of the nerve won't be there in these cases. So we can identify the other structures, and then according to those structures we can identify the nerves.
So when you identify one nerve, no, when you identify the one nerve and not the main trunk, then when you retrograde dissect, you can, because they are in the different planes, you can damage the other nerve branches.
Yes, sir.
And what is your experience with the nerve monitor?
So we in our center are using the nerve monitor in almost all the cases of parotidectomy, and it helps in the identification of the thinner or the small delicate branches of facial nerve, which could be injured in the dissection if we are not using the facial nerve. But yes, earlier also we did it without the intraoperative nerve monitoring. So it is possible to carry on without the intraoperative nerve monitoring, but it can be used as a precautionary measure to preserve the branches, especially in difficult cases where there are high grade malignancies, bulky tumors.
And recurrent cases.
Uh,
And if the final pathology showing if the it is a high grade and you have not done the neck dissection, will you do go ahead and again do the elective neck dissection in those cases?
So we can go for adjuvant treatment also, but for high grade, there are high chances of recurrence, and if possible, we should go for the neck dissection as a second stage procedure.
Is there any evidence for that?
Um, so
Dr. Sudipta, there is no evidence for that. You say you can go ahead with the post party anyway you are giving, so you can do radiation also. Most of the people don't go with the second stage neck dissection, rather than we go um,
adjuvant
for
treatment.
the post-op adjuvant therapy.
Yes.
Dr.
Dr.
Sowrabh, may
Khyati, you
I
have any
add?
Dr.
question?
Rudra,
Yeah, please, Doctor. So Dr. Khyati first, and then Dr. Akshat, please.
so Dr. Rudra, just one question.
Yes,
How
ma'am.
comfortable are you doing? How comfortable are you with doing extracapsular dissection in your center? Because initially extracapsular dissection was abandoned and a parotidectomy was done just to be safe on the nerve side. And if you study literature, the
Yes.
complication rates in most papers are equivalent.
Yes,
So
ma'am.
some papers do say that rates of facial nerve paralysis are less, but most other papers with larger series say that the rates are equivalent. So how comfortable are you people in your center?
Ma'am, personally, I feel, and what I read in the literature, extracapsular dissection is preferable for small tumors. But if the tumor is large, and also it is not indicated in larger tumors and in malignancies, in it should be done in unifocal tumors. But uh, also it needs experts hand in doing the extracapsular dissection because of the high chances of capsular breach and tumor spillage. So, yes, if the surgeon is confident and has great experience in parotidectomies, we can continue with the extracapsular dissection, and it is indicated to do extracapsular dissection in the smaller tumors when we don't need to identify the facial nerve, and also with the um, use of intraoperative nerve monitoring, it can again be used, because the disadvantage of extracapsular dissection was what the literature says is that the extracapsular dissection can cause facial nerve injury because of the blind dissection. But because we don't identify the nerve in extracapsular
Yeah,
dissection,
exactly.
but with the use of intraoperative nerve monitoring, we can look for uh, the nerve branches, and then we can do the extracapsular dissection.
Are you guys using it in your center or any
Yes,
other?
ma'am.
Okay,
Yes, ma'am.
okay.
So
Dr.
here
Akshat.
another important point is that extracapsular dissection, they suggest that you should be using magnification. That may be in the form of loops or even microscope. That is very essential so
Yes,
that you
sir.
don't miss out
Miss
on
out on branches.
the
Any
facial
nerve
nerve. So
branches. Yes, sir.
that's very important thing. And of course, facial nerve monitoring is required. Regarding the neck dissection part, if you are already, if it's an in plus neck, of course, there's no doubt. But regarding N0 necks, if you are mentally prepared or that has been discussed initially, you may do neck dissection at the time of surgery for higher grade or higher stage of tumors. Say if the skin involvement or it's very extensive, or if you're doing a level 2 sampling, probably based on that you can decide whether to do neck. But I won't go back to do a neck dissection just because tumor comes out to be higher grade or higher stage later on.
Okay, sir.
Like it was mentioned, I would rather give a radiotherapy or adjuvant therapy to the patient.
Okay, sir.
So great, nice presentation. Thank you.
Thank you, sir.
We can, I think we can go ahead with the next presentation, and thank you everyone.
Thank you.
I think next presentation is on radiation oncology. I think Dr. Jhendra is not there, so Dr. Arnav is present in his place from Max Specialty Hospital, and Dr. Prekshi is the mentor in that. Dr. Arnav?
Yes. Good evening to one and all.
Yeah.
So,
Please start.
hello.
Yeah, please start. Share your screen.
Yeah. Yes, sir. So, good evening to one and all. I'll be talking about role of radiation therapy in parotid carcinoma. So these are the following. These are the indications for radiation therapy in salivary gland tumors, salivary gland malignancies. So for local post-operative radiation therapy, we go for radiation therapy in stages T3 and T4. High-grade malignancies, perineural invasion. In the cases of closed resection, where the closed resection is 1 to 5 mm. In these cases, we give 60 grays radiation to the tumor bed, and incomplete resection. In the cases of incomplete resection, since there's a tumor left, so we give 66 grays. For regional postoperative radiation therapy, here we give radiation to radiation cases of nodal positivity, extranodal extension, and in elective cases, we give 50 grays to the ipsilateral neck. For primary radiation therapy, we give around 70 grays. In the cases of medically inoperable cases, functionally inoperable, unresectable cancers, and recurrent cases. So these were the trials that were done at Memorial Sloan Kettering Cancer Center, John Hopkins, MD Anderson, and Princess Margaret Hospital, and Massachusetts General Hospital, where we can clearly see a role of post-operative radiation therapy in cases of salivary gland malignancies. So we can see the benefit of combining post-operative radiation therapy with the surgery. So here we can see the local control is also better, and the survival is also better in all the cases. Next, going on to the role of radiation in treatment of malignant salivary gland tumors. So this was the study by Terhard et al. So in this, 386 out of 498 patients, we combined surgery with the postoperative radiation therapy with a median dose of 62 grays. And there was a median delay between the surgery and radiation therapy around 6 weeks. The elective radiation therapy to neck was given in 40% with a median dose of 50 grays. And in medically in unresectable cases, we gave radiation therapy as a primary modality. So post-operative radiation therapy, it improved the 10-year local control significantly compared with the surgery alone in the following cases. T3, T4 tumors, it was 84% as compared to 18% in surgery alone. the patients who had closed margin. So in this, we had a 95% 10-year local control as compared to 55%. In complete resection, we had an 82% response. Bone invasion 86% versus 54%. Perineural invasion 88% as compared to 60%. And local control was not correlated with the interval between the surgery and radiation therapy. The post-operative radiotherapy significantly improved the regional control in nodal positivity. As we can see here, 86% versus 62% for surgery alone. Now, since we are giving radiation to the parotid to the tumor bed, we need to understand the parotid bed clearly. So the parotid gland, it extends from the zygomatic arch superiorly to beyond the lower border of the mandible inferiorly. Posteriorly, the gland, it dips in the space between the mandible and the mastoid with the adjoining external auditory meatus, intimately surrounded by the gland in its free borders anteriorly and inferiorly. And on a deeper plane, the parotid is related to the styloid process and the muscles that are connected, which are the pterygoid muscles. Now, for loco-regional involvement, the local infiltration of the tissues adjacent to parotid is the main pattern of spread. So of middle cranial fossa, the neck of the mandible, external auditory meatus, inferior surface of the inferior surface of styloid process. So in radiation, we need to first simulate the patient. So for this, we need to position the patient well. So during positioning, we make the patient supine with the arms by side, and head and neck are hyperextended so that we can move the orbits out of the radiation field. Now, for immobilization, we use various techniques. In most of the cases, we use thermoplastic head and neck mask with the headrest and planning CT. So in this, we use 2.5 mm slices, and we take the CT scan from vertex to carina. MRI is fused with the planning CT for a better target delineation. Now, in conventional treatment fields, which is the 2D field as well, we use unilateral anterior and posterior wedged pair fields. Here, the superior boundary is the zygomatic arch. The inferiorly, we take the boundary as the posterior belly of the digastric muscle. Anteriorly, we take the masseter muscle. Posteriorly is the mastoid process. Laterally, we have the ramus of mandible, and medially, we have the styloid process. And in cases of superficial parotid tumors, we combine it with the electron treatment, as we can see here. So these are the boundaries of in case of electron treatment. So here we can see it is it's an inverted triangle. Now for conformal techniques, according to the UK COSTAR guidelines, the CTV1, it includes the parotid bed and any adjacent tissues which are at risk of microscopic spread, which are in the direct anatomic extension of the parotid. Level 1B, 2A, 2B, ipsilateral nodal stations. The TMG, it recommends including the ipsilateral lateral retropharyngeal lymph nodes, level 1B, level 2, and level 2B nodal stations within the CTV1, as they are the first draining lymph nodes of the parotid malignancies, and they are anatomically within close proximity to the parotid bed. Now, the CTV2, it includes the level 3, 4, and 5 ipsilateral nodal stations. Now we need to understand the anatomy in case of when we are doing the IMRT. So we will be discussing the anatomy, CT anatomical identification at various levels. First at the superior level, which is which is bounded superiorly by the CT slice, which is passing most lateral and superior extent of the zygomatic arch, and it is posteriorly bounded by the posterior most attachment of the pinna. Laterally, we have the skin here. Anteriorly, we have the posterior half of the masseter, and medially, we have the infratemporal fossa, soft tissue plane, in front of the base of skull. So here we can see the CT imaging at the level of zygomatic arch. Now, talking at the level of above and at the level of external auditory canal, anteriorly we have it follows the anterior border of the masseter. Medially we have parapharyngeal space and lateral pterygoid plate. Posteriorly, we have the lateral retropharyngeal soft tissue anterior, which is anterior to the skull base and including the external auditory canal. And laterally we have the skin. So here's the CT imaging of the same at the level of external auditory canal. Here we can see the parapharyngeal spaces which we are taking in the target. Now, below the level of external auditory canal, anteriorly we have the anterior border of masseter. Medially we have it includes the parapharyngeal space and lateral retropharyngeal nodes. Posteriorly we have the posterior border of mastoid process and soft tissue plane, and laterally we have the skin. In adenoid cystic carcinomas and in cases which have perineural invasion, the posterior margin, it must include the stylomastoid foramen. So here's the CT image of the same. Here we have included the stylomastoid foramen. Now, at the level of the mandible, anteriorly we have the submandibular gland, which includes the level 1B nodal volume. Medially, we have the medial border of 1B and submandibular gland to include the parapharyngeal space. Posteriorly, we have the 2A and 2B nodal volumes, and laterally the skin. Now, inferior level, we have this, it is at the level of superior cornu of the hyoid bone. So anteriorly, we include the submandibular gland. Medially, it is the medial border of 1B and submandibular gland to include the parapharyngeal space. Posteriorly, we include the level 2B lymph nodes going back to the sternocleidomastoid muscle. So here we have the posterior border at the sternocleidomastoid muscle. Now, the dose recommended for CTV1 in cases of post-operative in post-operative cases, we give at least 60 grays in 33 fractions, and in cases of high risk with such as the positive margin, we give around 66 grays. Ipsilateral neck radiation is given in cases of lymph node positive cases. So here we give 60 grays, and in cases of extranodal extension, we give 66 grays to the ipsilateral neck. If there is no indication of there is no indication of the contralateral neck irradiation, and in cases of definitive radiation, such as medically inoperable cases, as we discussed earlier, we give a dose of around 70 grays. So this was the COSTAR trial, which compared the 3D CRT versus IMRT for cochlear sparing. So it randomized patients in two groups. It was done at 22 centers of UK from August 2008 to February 2013. So in this, we compared the median dose to cochlea. In 3D CRT, it was around 56.2 grays, and in cochlear sparing IMRT, it was around 35.7 grays. So we compared the results at 12 months. It was shown to have 39% in 3D CRT and 36% in cochlear sparing IMRT. They had a hearing loss of more than 10 decibels. So IMRT allows an excellent coverage of the tumor while sparing the OARs as the organs at risk as compared to 3D CRT. Now, in this, the dose of eustachian tube, it stays under 45 to 50 grays. Mean dose to mastoid and external auditory canal in 3D CRT versus IMRT, it was 53 and 43 grays, 53 and 51 grays respectively. So IMRT is shown to be better. The mean dose to contralateral parotid was 1 gray, versus 9 grays in IMRT. Now talking about elective neck irradiation, the ipsilateral level 1B to 4, it should be included in the following cases. In cases of high-grade malignancies, T3, T4 tumors, the following histological subtypes: squamous cell carcinoma, adenocarcinoma, and undifferentiated carcinomas, and in salivary duct carcinomas. So here we give, in cases of elective neck irradiation, we give a dose of 46 to 50 grays. Now, the pattern of nodal recurrence, the median dose to the neck was 50 grays in 37 patients who were receiving 60 grays or more, and 5 and 10-year nodal relapse were 11 and 13% respectively, as shown by Chen et al. The 5 and 10-year nodal relapse was 7, 5%, 12%, and 16% for patients with T1, T2, T3, and T4 respectively. And the use of elective neck irradiation, it reduced the 10-year nodal failure from 26 to 0%. So it was a significant reduction. Now the association of adjuvant chemoradiation versus radiation therapy alone, as shown by Emini et al. So here we do not see much of a benefit of adding chemoradiation. Radiation therapy alone after in post-operative cases is beneficial enough. The addition of post-operative concurrent chemotherapy to the radiation in high-risk major salivary gland carcinomas, it did not have a overall survival advantage. So in case of radiation therapy, we apply bolus in the following cases. When there is skin involvement, which is a poor prognostic indicator for development of distant metastasis later on, and relatively low incidence for local recurrence. So in order to obtain adequate skin dose, the TMG, it recommends bolus in the following situations: when there is skin involvement and there is a closed superficial margin, and there is tumor spillage or capsule rupture. Now, re-irradiation in case of recurrent salivary gland tumors, as shown by Karam et al. Retreatment, it involves additional surgery and post-operative irradiation. So here we do fractionated stereotactic irradiation with a dose of 6 grays per fraction in 5 fractions. So it showed a 50% loco-regional control. However, re-irradiation is not advised within 1 year of the first radiation therapy received by the patient. Now, talking about the side effects of radiotherapy, acute side effects, they are seen within the first 90 days. So here we have skin reaction, xerostomia, and acute mucositis. These are all dependent on factors such as the site and the volume that we are treating, the fractionation regimen that we use, that we select, and the total dose that is being delivered. And the late side effects are pituitary dysfunction, temporal lobe necrosis, optic neuropathy, which is seen after 54 grays, keratitis, hearing loss, which is of sensory neural nature, and here we have a threshold of 45 grays. We can also see chronic otitis media as a long-term sequelae. Osteoradionecrosis, trismus, and hypothyroidism can also be seen in patients. Every patient should undergo pre-radiation dental evaluation, and if any extraction is necessary, it should be done before the initiation of radiation. Thank you.
Good presentation, Dr. Arnav. So if suppose there is a case of adenoid cystic carcinoma T2N0,
Yes,
and
ma'am.
margins are clear, So
Yes,
would you
ma'am.
like to give post-op RT in this case?
Yes, ma'am. I would like to.
And the reason is?
Ma'am, because it's a case of high-grade malignancy. We should give radiation in this patient.
Yes, actually, even in early stage adenoid cystic carcinoma, radiation,
Yes, ma'am.
post-op radiation reduces the locoregional recurrence rates. And also, since it is known to have PNI in most of the cases, so you have to cover the nerve also to the base of skull.
Okay, ma'am. Okay.
Then in one of your slides, you have shown that 60 gray CPV in 33 fractions. So
Yes, ma'am.
if the margins are clear and there is no ENE, then 60 gray 30 fraction
30
is
fraction.
the recommended dose. And you go till 66 in cases
Okay,
of
ma'am.
positive margins and extranodal extension. And what is
Okay,
the
ma'am.
dose which you give? Suppose if you are covering the nerve to the base of skull, so what is the dose which you like to prescribe for the nodal, for the nerve coverage, neural coverage?
Ma'am, I'm not very sure about this.
So around 54 gray,
Okay.
50 to 54 gray is the dose which you should give to the, you should trace
Base
the
of skull.
nerve till the base of skull, and then 54 gray, 50 to 54 gray. In our center, we are giving 54 gray.
Okay, ma'am.
Then an important point to note is, although they have mentioned that around 1% of the patient, they fail on the skin, but practically we have seen few patients which have skin nodules and they're recurrent. So it is very important to be cautious regarding the pre-operative clinical findings, the histopathology report, and a bolus to the skin, whenever it is indicated, needs to be applied.
Yes, ma'am. Yes,
And
ma'am.
then and a coverage of the intratemporal fossa and the parapharyngeal space definitely should be taken care of.
Okay. Yes, ma'am.
Dr. Arnab, in which cases you will not give post-op RT in malignant parotid tumors?
So you have to tell just the opposite of what you told in the indications.
Ma'am, low risk cases, low risk malignancy cases, and the tumors which are lesser than T3 grading. And in cases of where we do not have extranodal extension, and yeah.
So if it is node positive, then obviously you have to give.
Yes,
and
ma'am. We have to.
Extranodal extension comes after nodal positivity. So in early stage T1, T2, N0, low grade malignancies, margins clear.
Yes, ma'am.
And if they don't have any adverse risk features, those patients can be spared.
Okay.
So if it is a low-grade tumor and the margin is 2 millimeter, will you give radiotherapy in that?
Yes, sir, because there is a margin positivity is like there is a margin is less here. Only 2 mm is present, so we should give radiation in these cases.
So in
So
the
Dr.
parotid, the margin. Yeah, actually, you please. Okay.
So there is a question by Dr. Vibhay. So Arnav, will you include level 1B and level 2, level 5 in all the cases?
No, ma'am, not in all the cases. In cases which have extranodal extension, we would like to include from level 1B
No,
to
actually,
5.
that does not have anything to do with the extranodal
Okay.
extension. You first of all have to divide that whether it is node positive or you are giving elective nodal
Elective
irradiation.
node. Okay.
So if it is node positive, you have to include till level 5. But if
Okay.
it is node negative, then level 3 and some authors, they say that till level 4 we can take.
4.
Level 5 is not indicated in if the node is not negative. Nodes are negative pathologically.
Yes.
Thank you very much. I think we should go ahead with the last panel discussion.
Dr.
And,
Sowrabh, can I
yeah.
Can I
Yes.
play the devil's advocate and just to stir the hornet's nest?
Yeah, you are.
What margins would you be saying are okay for a parotid tumor? Would you want them to be 5 millimeter at least, or are you happy with lower margins also?
You are asking me?
Yes, to everyone actually,
Okay.
whosoever wants to answer.
So 5 millimeter
And
margin, guys,
even to the
difficult in
radiation
parotid.
oncologist present here.
So yeah, so they should. I think the radiation oncologists, they go with a margin in the parotid same as the buccal mucosa or in the tongue. That is not possible in parotid many a times if you are near to the facial nerve, and your margin will be 2 millimeter, 3 millimeter on the facial nerve. But if you have dissected completely or even 2 millimeter margin, it is a low grade tumor or low grade mucoepidermoid. I will not give radiotherapy to that patient, and I mean, it's not a sacrosanct margin of 5 millimeter in
Yeah,
parotid.
so exactly the point I wanted to make through this question. So at several places in parotid, we may not really have any, huge margin out there. So even couple of millimeters, and if we are happy with the resection, that should be adequate. We won't rush for radiotherapy in that case. And there are several studies which have shown that even lower margins may be acceptable, particularly close to facial nerve.
Because there is mostly a very distinct plane is there on the facial nerve, and if it is plane is clear, and even if your margin is 2 millimeter, it is fine. I think we should go ahead with the panel discussion now. I think a few questions will be there. So Dr. Abneet and from the Max Saket, he's the DNB student in the Max Saket. She will be the moderator for the panel discussion. Dr. Abneet, yeah. Dr. Abneet, are you
Sir,
here?
yes, sir, am I audible, sir?
Yeah, you are audible. And the panelists, second. The experts for this, mentors for this panel will be Dr. Akshat and Dr. Dodul. Dr. Dodul is radiation oncologist in Max Arcade. Dr. Akshat is head and neck oncosurgeon in Max Arcade. And the panelists are Dr. Kaushik from Rajiv Gandhi. He is a surgical oncologist, DNB. Dr. Abhishek is DNB medical oncology student from Medanta. Dr. Sonam is radiation oncologist. DNB from Dhamshila, and Dr. Akhil is surgical oncology DNB from Max Vaishali, and Dr. Shobna is senior resident in Max Saket. All are here?
Yes.
Yes, sir.
Okay. So Dr. Avneet, please go ahead. You have only 25 minutes, and I think you can cover 2 cases. Okay.
Yes, sir. Sir, is my screen visible, sir?
Yes, screen is visible.
Okay, sir. So we'll start with the panel discussion. The first case, it's a 48-year-old female who presented with a swelling in front of the ear lobule for last 3 months, which is gradually increasing in size. I would like to ask.
May I interrupt?
Yes, sir.
This is a book picture. This is a book picture. It's a real patient picture. Because this picture was there in the one of the presentation also there earlier. That was not from Max Saket.
No, sir. This is a book picture, sir.
Okay.
So my question is, what points in the history should be asked?
Dr. Abneet, can you please ask the question to specific panelists?
Yes, I would like to ask the question to the surgical oncology resident to what further points in history will should we be asking in this patient?
Good evening, ma'am. We would be specifically asking for pain, the rate of progression, duration of complaints, signs of facial nerve involvement, if any.
Okay. So going ahead with the presentation. So this patient presented with the pain, but there were no other swellings in the neck. There was no history which was suggestive of facial nerve weakness. There was no history of difficulty in swallowing. Further, this patient was also not associated, this swelling was not associated with fever, redness, and discharge. Is there any significant past history which should be elicited in this patient?
Ma'am, we should know if there is any swelling that the patient had, similar swelling in the that the patient had previously, and any surgery or history of radiation that the patient received previously.
Any other points? Okay. Is there any significant personal history or any addictions which any history that should be elicited?
Ma'am,
Smoking, alcohol.
So this patient had no history of any radiation exposure, no previous swellings, and no history of any addiction. So could
So,
anybody from the
Avneet,
surgical...
before you move
Yes.
forward, see, you don't have to rush through the presentation. You need to delve on points, and learning points should be apparent for everyone. So, if you're talking about smoking, how is that related to these parotid swellings? It's for you as well as for all the panelists. And don't just blankly ask questions. You can ask individual people, and you can ask for everyone's opinion before you move forward. All right.
Yes. So smoking is associated with increased risk of carcinoma in parotid gland. And also radiation exposure is also associated with an increased risk, is why I asked the question.
What other swelling will you expect if a patient is a smoker?
So it can be a lymph node also in the parotid region. That is why it is important to elicit the history of smoking and alcohol to see if there is any other head and neck malignancy that is causing the swelling in the site.
All right. And anything else?
So smoking and alcohol is associated mostly with the Warthin tumor, which is a benign tumor seen mostly in the elderly population, and it's a very slow growing tumor and can be kept for watchful observation. So this is...
Yeah, in fact, it's debatable whether Warthin should be included as a tumor or not. So definitely Warthin should be kept in the book, and also it may be bilateral. That's another important thing of note. All right, Avneet, carry on, please.
Okay. I would like to request somebody from the surgical oncology resident to kindly describe the lesion.
Ma'am, this would be a round to globular swelling. Looks firm in consistency. It looks on infection in the region of right parotid gland, with lifting of the ear lobule extending approximately inferiorly up to the mandible and superiorly to the region of zygoma, anteriorly to the anterior border of masseter and posteriorly to the mastoid.
Okay. So these are the boundaries of the parotid. These are the boundaries of the parotid region, and are there any cranial nerves which we would like to examine for this patient? And is there something else, some other region that we would like to examine in this patient?
We would like to examine the neck also, and we should examine for signs of facial nerve palsy, if any.
Okay. And for the deep lobe, how?
Deep lobe, we should palpate intraorally to look for any cross swelling along the medial wall of the oral cavity or the pharynx. Tonsillar fossa.
Okay. Could you please also tell how would be the facial nerve? How would we illustrate the facial nerve if there is any facial nerve involvement?
We would look for loss of the nasolabial fold, puffing of the cheek, and on closing the eyeball, lag of thalamus, and we would ask the patient to look up, and we would look for loss of creases on the forehead, and deviation of angle of mouth.
Oh, okay. And if there is any facial nerve, if there is an involvement of the facial nerve, what grading system do we usually use to describe the dysfunction?
And we would be
Yes, house blood. Okay.
So how many
So
of you will also examine other lymph node stations? Like you are all considering it that it's a primary parotid malignancy or a salivary gland tumor. It can be a lymphoma as well. So how many of you will also like to examine other lymph node stations like axilla or other lymph node areas?
sir, we should be examining the other areas as well, but since the patient has not given any history of uh, any other lesions anywhere else in the body or any prior history of uh, any other malignancy.
No, so that is not the way. Once you are having a swelling over the parotid region, that can be a lymph node mass, that can be a parotid mass. And if it is a parotid mass, then it can be a primary salivary gland tumor. There is a high possibility that it can be a lymphoma as well. So until and unless you are having a proven diagnosis, like you are having an FNC report or a biopsy report, you do not know what is this. So clinically, when you are examining the patient, you have to keep in mind that patient may not complain or may not be able to know whether they are having any other lymphadenopathy or not. So examining for other lymph node stations should be a part of your examination, clinical examination.
Yes. On examination, the skin over the swelling was free. On oral cavity examination, there was no oropharyngeal or uvular bulge. There were no palpable lymph nodes, and facial nerve function was found to be normal on examination. Further, I would like to ask residents from all the teams, what all radiological investigations would you like to order, in what sequence, and why?
Dr. Abnit, please be specific in asking questions, like you, the specific person rather than all or someone.
Okay, so what like I would like to ask the surgical oncology resident, which radiological investigations would you be recommending, in what order?
First, we would like to go ahead with CT or MRI of the parotid region. And then we would like to go ahead for confirmational FNAC swelling once the imaging is done.
Okay. Would
Ask others also, please.
would any radiation oncology resident recommend any other investigation prior to CT?
Ultrasound with FNAC, ultrasound guided FNAC, and followed by imaging with CT with IV contrast or an MRI with IV contrast.
Okay. Why the ultrasound?
Ultrasound will help us to identify if the lesion is the location of the lesion, the consistency, the texture of the lesion, if it is homogeneous or heterogeneous. And we'll have a fair idea of what kind of lesion it can be, benign or malignant. And it also helps us in taking a guided sample from the tumor to assess if it is a benign versus malignant lesion.
Oh, okay. Could you also tell me what are the disadvantages of ultrasound in a parotid lesion?
Ma'am,
Of a parotid lesion.
It is difficult to assess the deep lobe of the parotid with an ultrasound, and neck nodes assessment cannot be done if we're looking at just the parotid region with the ultrasound. And soft tissue, a local extent of the disease also will not be very clearly evident.
So nodes we can assess on the ultrasound
Yes,
also.
we are doing the ultrasound neck, yes.
Yeah. Okay.
So,
So,
Dr. Shobna, ultrasound has many more limitations when you are using it for assessment of a lesion. Like all the soft tissue details, like the neurological details, the nerve details, extension to parapharyngeal space, extension to deeper plane, extension to base of skull, you may not be able to appreciate on an ultrasound.
Yes, sir. Yes, sir.
So, what other imaging modality would you guys prefer?
Or to put the question in a straightforward, what will be your preferred investigation when you are having a parotid swelling? What will you prefer?
So,
Someone told PET CT. Is PET CT a routine recommendation for parotid tumor? If not, then what is the specific recommendation for PET CT? What stage or what kind of tumor?
So the preferred investigation would be MRI of face and neck with IV contrast, and PET CT is usually recommended for high-grade tumors and significant neck nodal burden, cervical node involvement, where we want to look for any distant metastasis. Otherwise,
Yes, so high grade and advanced stage.
Yes, sir.
So for a low grade tumor or a
No, you should let
N0,
other people also answer.
Yeah.
Okay, sir.
So who else is there? Anyone from
I think
medical side?
medical oncologist Dr. Abhishek is there from Medanta. Dr. Abhishek, when you will do
Yes,
the
sir. I want to add something that CECT head and neck is the preferred imaging modality of choice, and MRI can be added if there is peridural extension or there is soft tissue extension or there is skull base involvement or there is
Abhishek,
intracranial extension.
that is incorrect actually. For parotid, preferred modality is contrast enhanced MRI. You would do CT only if you have some doubt of bony involvement. That also majority of times MRI is good enough to tell you. All right. So don't mention CT when you're talking of parotid because we want to see facial nerve involvement, and that is not being answered by the CT scan.
Okay, accepted.
okay. Should I go ahead, sir?
Yes, please.
Okay. So we've heard of ultrasound, CT, MRI, and PET CT, as has been answered by our experts.
No, wait. So someone mentioned PET CT also. If you're having a upfront parotid swelling, would you like to do PET, or when would you prefer doing a PET scan? Surgical oncologist can answer this, please.
In case of high-grade tumors, T3, T4 lesion, adenoid cystic carcinoma, and in the event of high nodal
All
burden in
these
the
things
neck.
you are telling me once you have the cytological proof of the tumor. All right. Now the patient has come to you for the first time, and you will probably be writing the investigation there at that very time, rather than telling the patient, okay, that we need a diagnosis, and then probably I'll decide what imaging I'm looking for. So what would be your recommendation? Like patient will ask, should I get a PET scan done? Will that be helpful in my case? What would you suggest then? Or what are the limitations of
Unless
PET
we
scan?
suspect,
So
unless we
initially,
suspect
when
a
the
high-grade malignancy, we are not suggesting a PET.
Yes, but normally you don't prefer doing a PET scan because PET cannot. Avneet, please answer. You have put it on the screen also. You can answer this.
Yes, sir. So initially, when the patient comes to us without a cytological or a histopathological proof, we should not go for a PET CT because it cannot help us to distinguish between a benign and a malignant parotid tumor. It can only help us to it can only help us to stage the tumor if it is metastatic or whenever the patient has a high nodal burden in the assessment of regional lymph nodes.
So there are some indication for PET scan sometime upfront also along with the MRI, not alone PET scan. Like if the tumor is fixed to the skin, fixed to the underlying structure, you know that it is a very high grade tumor clinically. Facial nerve paralysis already there. In those cases, and the multiple lymph nodes are involved, multiple lymph node station are involved. Those cases, PET scan should be done and along with the MRI, not alone.
To add to it more, just like one liner, if you are having a histological confirmation of lymphoma or high grade lymphoma like DLBCL, then in lymphoma staging workup, PET-CT has to be routinely recommended.
Hello.
Ma'am, I think it can be assessed on the imaging, but I'm not sure of the marker.
Oh, okay. If somebody from the surgical oncology team could help us regarding this question.
Ma'am, regarding the marker, I'm also not
Uh, the medical oncology resident.
No, go regarding the markers for facial, no particularly.
Okay. So going ahead, the usually the surrogate marker for imaging is the retromandibular vein, which is located posterior to the mandibular ramus. It is usually lateral to the cranial nerve 7, that is facial nerve is lateral to the retromandibular vein. So going on next, talking about the FNSE.
So point to understand out here is that on MRI, you don't really see the facial nerve, but you see the retromandibular vein. Based on that, you decide whether the deep lobe is involved or not involved, or whether facial nerve may be engulfed by the tumor or not engulfed. Clinically, patient may not have any symptoms, but based on what you're seeing on radiology, you can decide that. So you need to look for retromandibular vein.
Yes.
Move on, please.
Okay. So my question is, should FNSE be done in each and every case? And what are the reasons for your respective answers? Can the surgical oncology resident answer this?
FNAC should be done to come up with a working diagnosis to define whether it is benign or malignant so that we plan our surgery accordingly.
Okay. Are you anyhow aware of any kind of data or any kind of sensitivity or specificity values for FNSC in parotid swelling?
No, before you move on with that, please answer what else will FNC tell you? One is benign malignant. What else does the FNC tell you?
Not sure.
Phase of the tumor.
It will grade the tumor.
Grade the tumor. Majority of times they may not be able to tell you. Sometimes they may. But the point is, not many, but occasionally some of these parotid swellings may be something else.
Metastasis can be a metastasis.
Can be metastasis
or a lymphoma.
Metastasis you will come to know. It could be lymphoma. Or what else can be there? Any inflammatory conditions of parotid?
Sjogren's or tuberculosis.
Yes. So there are several conditions where you may not directly jump ahead with surgery. You need to be sure that this is a surgical condition and then only you need to go in. So this is where FNEC is useful.
Yes.
Now I think the other question was regarding benign and malignant. So go ahead, Avneet, please.
Can anybody from the medical oncology team help us with telling us what could be the sensitivity of FNSE when it comes to benign versus malignant?
There is no such data mentioned in the literature. What is it? But actually, a negative FNC does not rule out that there is no tumor or one is benign or malignant, because it is not telling about the cellular architecture. So a core biopsy will be more beneficial to distinguish between the two.
Does the radiation oncology resident have any approximate values for the sensitivity or the specificity for FNAC?
Ma'am, I think it's somewhere between 70 to 80% sensitivity, and specificity is between 80 to 80% for FNAC.
Okay. So there is a okay. So there is also a reporting system for the cytopathology, which we had just discussed in the
Avneet,
first.
Avneet, 1 second. I think I just want to ask Dr. Abhishek. In your hospital, you do biopsy, root cut biopsy for all the patient, or you do FNAC for the parotid?
Sir, actually, as medical oncology, we have to deal with parotid only in cases which are malignant or which are inoperable or which need adjuvant treatment along with radiotherapy. So in all that cases, we have a two-cut biopsy for that.
So in
How
your
does
exam,
a two-cut be more beneficial? Sorry, please go ahead. Please go ahead.
in your exam, it will not come like that. In your exam, if the patient will be given to you, it will be have a parotid swelling only. It may not be that the patient is inoperable, then it will come to you. So you have to think from that point of view, not when the patient has come to you, recurrent cases or the pathology you have to find out.
So
And you have to
even
therapy.
in those cases, core biopsy is
Yes.
not always needed. Majority of times, FNAC alone is good enough.
Yes.
Avneet, do you have any slide on what percentage you were asking for? Do you have that slide on the
Yes, sir. Yes, sir.
meta-analysis?
Yes, sir. So there is a meta-analysis of multiple studies which has shown the sensitivity and specificity of distinguishing both between neoplastic and non-neoplastic, as well as benign versus malignant. So non-neoplastic versus neoplastic, the sensitivity is as high as 96%. The specificity is around 98%. And benign versus malignant is sensitivity is 80% and specificity is 97%. And preoperative FNAC is recommended because it can help to change the clinical approach in almost as high as 35% of patients, and it can help us with the better counseling regarding the tumor, extent of resection, and likelihood of neck dissection as well.
Taking this forward to what Abhishek was mentioning, when would you actually need a core biopsy? Anyone to answer that? Shobna, you want to answer it?
Sir, I think when the FNAC is not giving a confirmatory diagnosis, when it is equivocal, or when there is deep lobe involvement for getting more amount of tissue and for better
Sir,
evaluation.
With your respect, sir, I want to add something.
Yeah.
Actually, sir, FNAC is helpful for the surgical decisions, basically. That even if a negative FNA does not rule out that there is no tumor.
So negative FNA would be there, and hardly in majority of cases you will get a diagnosis with FNA. That is what that meta-analysis is telling, if you will understand that. All right. Very rarely you will find that FNAC is not really helpful, and there you can go ahead with core biopsy. Majority of the patients will come across, even if it is recurrent tumor, or even if you are talking of wanting to give palliative chemotherapy, you just need a diagnosis of malignancy. All right.
I think
That information is core biopsy providing you.
I think Dr. Abhishek, the Abhishek's question is, what is the harm to do a core biopsy rather than FNAC?
There is no harm.
Actually, the other thing is for further planning. Actually, for basically as medical oncology, we have to deal with the chemo part basically. So we have to go for the molecular classification. For that, FNA
So
tissue
Abhishek, that is a very select and small subgroup. That is a very select and small subgroup. You may be facing such patients, but if you're sitting in a clinic, not all patients coming to you will be like that. You will be having a mixed bag. All right. So you need to answer from that perspective.
Yeah. So Abhishek, you have to understand one thing. You are going in the exam as an oncologist, not medical oncologist only. Okay. So you are oncologist first and then medical oncologist. So you have to think on those lines when you go for exams. Yes, in practice, it is fine. You are sitting in a medical oncology OPD and already filtered cases are coming to you. But in the exam, it will be a first time case will come to you. It has not may not be seen by even the surgical oncologist. It is directly coming to you.
Okay.
And there's no harm in doing core biopsy. You can, of course, do core biopsy. Do you have any? Avni, do you have any numbers on core biopsy sensitivity specificity also?
Yes, sir, we do, sir. So, core biopsy, we have sensitivity. It was found to have more. Found to have more accuracy than FNAC with a sensitivity of 92% and a specificity of as high as 100%. But the morbidity was also less, but with experienced hands. But there was a slight higher chances of the facial nerve paralysis. But as of now, the current evidence is only limited whenever the FNAC is equal or whenever we are assessing certain lymphoid lesions or to perform IHC on the sample.
Yeah, so if you need to do IHC or like Abhishek mentioned, if you want to do any molecular testing, then you can go ahead with core biopsy. Or even if your institution prefers doing a core biopsy, sometimes that is also done. Like in UK, we used to do core biopsy routinely, but that's an institutional protocol. Okay, let's go back to your previous slide wherever you were.
Okay, so I would also like to ask the surgical oncology resident that are you aware of any grading system of the cytopathology for salivary gland tumors?
Milan grading, no?
Okay.
Milan system.
Okay. So as we have discussed, it is the Milan grading, which is graded from 1 to 6, and the risk of malignancy is from 25 to 90%. Going ahead, so the patient which we just discussed, this is the imaging for the patient. So I would like to ask the surgical oncology resident that looking at this imaging, what surgery should be offered to the patient, and will the facial nerve, according to you, will be sacrificed in this case?
This patient would warrant a total paratidectomy because the deep lobe also seems to be involved, and the facial nerve might need to be sacrificed.
So how will we assess that the facial nerve needs to be sacrificed?
We need to go.
Hello.
Hello.
Yes. So how can we assess that
Intraoperatively,
the
we need
facial?
to assess for involvement, or we can assess for with a MRI radiology, with an MR imaging.
Okay. So finally, as discussed, it is the intraop assessment that we'll be going forward with. So also, I'd also like to ask the surgical oncology resident. This was also a small swelling in the preauricular region, and this is the imaging for this patient. The FNAC was suggestive of a pleomorphic adenoma. So can an extracapsular dissection be attempted in this case?
Yes, ma'am.
Okay.
Extracapsular dissection can be attempted because it seems to involve only the tail of the gland and is located in the lower portion of the gland.
Okay. Going forward, so this is the next case that we wanted to discuss. So this lady had the large swelling on the left side of preauricular region.
Can you go back to the previous slide? Sorry, I missed that. You were asking whether extracapsular dissection should be done for this.
Yes, sir.
So as you can see, it's actually going to the deep lobe as well. I'm not too comfortable doing extracapsular dissection for this specific case. I would rather be happy doing extracapsular dissection for a smaller lesion more so in tail parotid or more superficial. For something so deep, I would not be doing a extracapsular dissection. I would rather see the facial nerve.
Okay.
All right. So your decision depends on that, how the lesion appears and where it is located, based on that, and of course cytology.
It is not only in the tail, it is going in front of the ear. If you can see that, and you can appreciate in front of tragus the tumor is there.
Yeah, and the deep lobe is completely involved. You can see it coming close
Yeah,
to the
yeah,
tendinoid plates.
yeah.
Okay, let's move on.
So this was a lady with a large tumor in the preauricular region, and these are the scans. So, what surgery would you go ahead with? I would like to ask the surgical oncology resident.
This patient would again go for a total parotidectomy since the deep lobe seems to be involved.
There is also involvement of the skin. So, would we take the skin as well? And it's also
With rotation.
invading the.
Yes, ma'am.
So what are the various types of parotidectomy you can do? There was, of course, a classification which is mentioned previously in the slides, not here, but in the previous presentation. But besides that, what are the general labels which you give for the parotidectomies?
Could be a superficial parotidectomy, could be a conservative parotidectomy, or total parotidectomy.
And it can be a total or radical, or it could be an extended radical. So here you are doing an
Yes.
extended radical. You are removing the skin also, and I'm not able to see what's its relationship with the mandible and the scans provided. But depending on how things are, you may end up doing a posterior segmental mandibulectomy also at times.
I think if you somebody asks with this photo that you which kind of parotidectomy you want to do, you can ask the question what is the pathology at least first. Okay.
Yeah,
Not,
definitely.
not jump onto the which kind of parotidectomy you are going to. You will do or not. First, you have to take that decision, and then you come to that which kind of parotidectomy you want to do.
Yes.
Absolutely. In fact, if you will see out here, inside it is not that infiltrative. Like outside is coming there, skin is of course
Yes.
involved.
Yes.
Inside the planes are very well maintained with the vessels and all. So
yes.
Sure.
So intraoperatively, how will you assess the facial nerve? Like what will you do? You will reach the facial nerve and then what?
And then we would try to create a plane between the tumor and the facial nerve to look for its involvement, or with a nerve monitor.
So how will a nerve monitor guide your decision making? What you said first was right, that you are trying to create a plane. So
Sorry,
what are the implications after that?
If the tumor is closely adherent and we are unable to create a plane, then it means, and if the facial nerve was involved preoperatively, like the function was compromised, then we would assume that the facial nerve is involved or infiltrated by the tumor. And then we would think of sacrificing either that branch or accordingly, and we would send a frozen section to assess for involvement of the margins and then decide on reconstruction accordingly.
Okay, and if facial nerve was functioning pre-op and then you intra-op, you are not able to find a plane, then what will you do?
We would try to preserve the nerve as much as possible if it was functioning preoperatively.
Yeah, so first of all, you need to ask whether this is regarding a specific branch or the main trunk. Secondly, whether the tumor is completely engulfing it or you can still shave it off the nerve. All right. Unless the nerve is completely engulfed, you still try and shave it off the nerve if possible. If only a branch is completely engulfed, you can of course sacrifice it. For the trunk, you will of course be a bit hesitant. And if you cannot get any plane and the deep lobe is also involved, and then probably you might need to sacrifice it.
Yes.
Dr. Avneet, I think you should go ahead with some radiation oncology question, and
Yeah.
then I think we will wrap up that after that.
Okay, sir. So we've discussed the intraoperative nerve monitoring. The evidence of that is it is not it is helpful in the post-operative in reduction in post-operative paralysis, but not in permanent facial nerve impairment. But whenever we have the provision, we can use it. And intraoperative frozen section, I would do. So should I ask, or should we go to the radiation oncology part?
You can probably just answer it yourself and move on, because I think we have to wrap up because of the time.
Yes, you can answer.
Oh, so intraoperative frozen sections are whenever we have the facility for intraoperative frozen section, we should go for that. And this is data which was suggestive of the discrepancies in FNAC and frozen section, and finally the histopathology and how the clinical consequences was changed because of the frozen section. So the data says that although it has a specificity which is similar to the FNAC, but it has a higher FNAC, if it has a higher sensitivity. So it can be done in cases whenever we have to refine the diagnosis of FNAC or identify nodal mets, or whenever we have to rule out facial nerve involvement, uh, especially in adenoid cystic malignancies, we'll have to drill and send the proximal margin till the time we get the negative margins before we can actually address, before we can actually close. Our next topic was lymphadenectomy. What is done in case of a N0 disease, the role of level 2 sampling, and what levels of neck are addressed in case of a node positive disease.
It is
In
already
case
been
of,
discussed, I think. It is discussed in
yes,
the presentation. Okay.
yes, sir, has been discussed. So coming to the radiation part. So in adjuvant therapy, when should the adjuvant radiation be considered, and what is the total dose and fractionation? And is there any preferred modality these days that we are preferring for radiation? And what is the radiation field? We're talking about this case, and given the pathology of the case is adenoid cystic carcinoma. So till where will we go for the radiation field?
The indications for adjuvant radiation therapy is T3, T4 cancers with the closer positive margin, and high-grade histology with the skin or bone involvement, and lymph node metastasis. And also in recurrent setting, we should always go for adjuvant radiation therapy post surgery, and and especially for the perineural involvement, we should always give adjuvant radiation therapy, and deep lobe parotid involvement is also an indication for adjuvant radiation therapy.
Do we give radiation in some upfront cases as well?
Upfront cases which are medically inoperable or unresectable tumors, there we can give upfront radiation therapy to a dose of approximately 70 gray.
Okay. So as we have discussed, these are the indications for radiation therapy. And
In those palliative cases, what sort of radiation would you prefer?
So for palliative cases, if it is inoperable upfront, we go ahead and give a radiation dose of 70 gray, 2 gray per fraction in 35.
No, I'm talking about the modality, like
okay.
What particles will you prefer?
Sir, in our center and in most of the centers, because of the availability, IMRT is preferred over 3D CRT. But in palliative setting, there is some data that says that there is much better benefit with using neutrons and proton-based treatments.
Yeah, that's true. So this you need to be aware of, that there's benefit of using heavier particles out here.
And the difference in the radiation, the extent of radiation field in case of adenoid cystic pathology.
As with adenoid cystic, there is a higher chances of perineural invasion. So the radiation field should include the up to the base of skull. So that is one thing.
I think this was discussed. We can move on.
Okay.
We have a couple of questions regarding palliative, chemo also. Yeah, okay.
Yes.
Molecular oncology.
So I would like to ask the medical oncology resident. So is there any data on adjuvant chemoradiation or upfront chemoradiation?
Actually, if there is presence of advanced pathological features like intermediate or high grade disease, or the margins are positive or margins are close, or there is PNI or LVI lymphovascular invasion, or there is T3 or T4A disease, we can use adjuvant RT or adjuvant chemoradiation. But there is a trial RTOT 1108. The results are upcoming for this. So they are just extrapolating the data that is to treat like squamous cell carcinoma of head and neck.
Okay, so with the data that we have as of now, does chemoradiation have any survival benefits?
There is no survival benefit, as it was mentioned by the radiation oncology resident earlier also. So there is no overall survival benefit. But it can be used if there are margin positive, there is lymphovascular invasion. Or external extension.
So, as discussed, these are the indications which can be considered, but we have the NCDB data which says that there is no risk, there is no overall survival benefit of. Yes. So let's come to the next case. This is a recurrent case. So this patient had a history of parotid surgery. The exact documents were not available 5 years back, and now she presents with a swelling in the preauricular area. And how should the swelling be approached? We went ahead with the CT scan, and this was the CT scan. And I would like to ask the surgical oncology resident, how would you like to approach the swelling?
We would like to initially do a FNAC to confirm.
Okay, so the FNAC which was done was suggestive of a mucoepidermoid carcinoma.
We would like to assess if it is metastatic or not. So we would like to go ahead with the PET-CT.
The PET-CT was done. It was suggestive of localized recurrence.
Then we would like to assess for resection. Was radiation given in the prior setting or not?
No, the radiation was not given. Yes.
So we would like to consider for re-surgery.
Okay. So let's say if the patient underwent a PET-CT and there was metastatic disease in the PET-CT, so would the approach change, and what would be the line of management? I would like to ask the medical oncology resident.
Yeah, actually, let me confirm this first. Are we talking about the patient shown earlier? What was the performance score of that patient? So,
what could you please repeat your question?
What was the PS of that patient? Actually, the management will depend upon whether we are going for a palliative intent or for a therapeutic treatment. So, first thing is, what is the PS of the patient?
The PS is 1.
Okay, PS 1. So we will, and if this is not a life-threatening condition, we will go for that molecular molecular classification of the biopsy. And based on that molecular analysis, it will be better to plan for that treatment.
We are talking about the recurrent case or the adenoid cystic one?
Yes, sir. This is a recurrent metastatic disease.
So as of now, we're discussing it as a recurrent mucoepidermoid.
Okay. So we will go with the molecular classification, and if needed for an emergency basis, we can go for a cisplatin, vinorelbine based, or cisplatin cyclophos or adjuvant based chemotherapy.
Okay.
But the preferred will be the
Similar-
molecular assessment, and based on that, target therapy will be preferred.
So Dr.
Okay,
Abhishek, if it is a asymptomatic disease, will you still go ahead with the even only the metastasis is there? There is no primary disease there. Will you still go with the treatment, whatever you have told with the cisplatin-based chemotherapy in the asymptomatic patient?
Sir, I don't think that if the PS is good and the treatment intent is therapeutic, we will go with chemotherapy.
No, it's not a therapeutic. It will be palliative treatment. It is a
Metastatic,
metastasis.
it will be palliative only.
It will be palliative only. What do you mean by therapeutic in this case?
So if that's why I asked the PS of the patient. If the PS is good, we will treat it aggressively. If the PS is poor, we will manage on a palliative basis. And she said the PS
So
is
you
one.
don't understand. So it doesn't depend on the PS if you have to go with the palliative or the therapeutic treatment. If it is a metastatic disease, it is a palliative treatment. Depending on the patient PS, you will decide your chemotherapy regime.
Okay, sir. Actually, it is mentioned that the choice of systemic therapy will be individualized based on the patient characters, based on the PS and the goal of therapy. So, if a young patient with a good PS, we can go for a therapeutic. We will go aggressively.
So what is your
aggressively,
therapeutic?
but it won't be therapeutic. It won't be therapeutic yet. It will still be palliative only. Only places we're considering curative intent would be probably if it's an adenoid cystic CA with oligometastatic disease. There we would still go ahead with surgery for the primary lesion, and for meds probably we can take care of them through probably surgery, radiation, or chemotherapy as well. But there also you would only intervene, say if the meds are increasing in size or if the patient is getting symptomatic. A huge advanced survival. You would of course want to do it.
My question is in the asymptomatic patient, say in adenoid cystic carcinoma patient presented maybe 2 years down the line, or like this patient 5 years down the line in adenoid cystic carcinoma with METs, will you like to give chemotherapy if the PS1 is there, or you will wait if the patient is not symptomatic?
Sir, I'm not sure, but from my side, we should offer the patient chemotherapy.
Which chemotherapy will you give adenoid cystic carcinoma?
Adenoid cystic, sir, we will prefer cisplatin, cyclophos, and doxorubicin.
Is any data there which suggests that?
Yes, sir, there is data that they have shown that the duration of response is of approximately 5 months. And with cisplatin and vinorelbine, the data is approximately for
5 months asymptomatic adenoid cystic carcinoma. Life is more than 5 months anytime.
You would actually not intervene right away. In adenoid cystic C, if patient is asymptomatic, you put them on surveillance. You will repeat the scan, say in few months' time. Only if the lesions are increasing rapidly, or say they are getting doubled up in size in less than 4 to 6 months, or if the patient is becoming symptomatic, then you would want to intervene. Adenoid cystic C is it's an indolent disease. We are not too trigger happy with any sort of treatment.
So, sir, in that case, if this is not urgency, we will prefer the molecular results to come and we will start oral targeted therapy.
Yeah,
Which
we
oral
can do
targeted therapy in adenoid cystic? Which oral targeted therapy?
Sir?
Which oral targeted therapy in adenoid cystic carcinoma?
Sir, there are multiple options based on the what the molecular result shows. If there is they are androgen receptor positive, we can go with biagulutamide. If they are anti-KIR receptor gene fusion tumors, we can go with entrectinib. If they are
So
HER positive,
depending on what histology you are having, accordingly we expect the mutations to be there. All right, Avni, do you have any slide on that? What mutations we
Yes.
expect? All right, can you show that?
Yes. So based on the mutations, there are various phase 2 trials which are being done based on the mutations that are and the targeted therapy which can be given. These are under phase 2 trials only, and some of these molecular markers the NCCN has also recommended. This is the data from NCCN.
Yeah. Okay, I think we should conclude now. Say, please. Please, Abhishek. Yeah, Abhishek, you want to say something?
Yes, that sir, I was saying that I was putting this line: the choice of systemic therapy should be visualized based on patient characters.
Okay. Okay, so I think we should conclude now. It is already 9:30, and we are almost over time. Thank you very much. Thank you very much, everyone. Thank you, Avneet and Akshat, Dr. Dodul. I think he has to leave. So thank you, and thank you, Oncology Forum, for this class.
Thank you, sir.
Thank you, sir.
All right.
Thank you.
Thank you.